Very good afternoon, viewers. I welcome you all on behalf of Clinical Infectious Disease Society, CIDS, for this webinar series on COVID-19. And all good things has to come to an end. And this is our last lecture, the 6th lecture of our webinar series. And the lecture topic is lessons learned from other nations, the way forward for India. I think India right now is in a crucial juncture where we are clocking around 11,000 cases, and then what will be the way forward for India? And Dr. George M. Varghese, who is a professor of medicine and infectious diseases at Christian Medical College, Vellore, he will be the speaker. And Dr. Ram Gopalakrishnan, who is a senior consultant in infectious diseases at Apollo Hospitals, Chennai, will be the moderator for the session. A few announcements as usual, and please key in questions or ask questions that is relevant to the current day talk. That is what I would request all the viewers to do. And people who join in late, who miss the live action, here probably can watch it in YouTube, where you'll have to type in CIDS webinars for getting access to this lecture, as well as the prior 5 lectures. All you have to do to go to the YouTube and type CIDS webinars, and you would have access to all these lectures. And we could also access all these lectures plus the current lecture that's going to be given by Dr. George M. Varghese tomorrow from our CIDS website, which is CIDSindia.org, which again has a section on COVID-19, which has authentic and very good material that is relevant to this current scenario. And with this, I would hand over the proceedings to Dr. Ram Gopalakrishnan to start with. Thank you.
Good afternoon, everybody. Thank you very much for attending this webinar, the last of the series. It's a pleasure today to introduce Professor George M. Varghese. He's my good friend. He is currently a professor in the Department of Medicine and Infectious Disease at Christian Medical College, Vellore. George is an accomplished person in the field of infectious disease. You could call him Mr. Scrub Typhus, if I might take your permission to call you that, George. George has done most of the pioneering work from epidemiology, clinical features, treatment to scrub typhus, and if clinicians today diagnose scrub typhus like that, it's probably because of George's work. So he's also very special to our society because he's one of the guys who keeps pushing us right from the beginning and is essentially the backbone of our society, of running our annual conferences, etc. The society is very thankful to him for that kind of work. George is an excellent systematic speaker, and I'm sure he's going to do a great job today. Over to you, George.
Thank you, Dr. Ram, for your kind words of introduction. Good afternoon, everyone. This pandemic has made us introspect, think, and act in different ways. Each of us have our own views on many of the issues. I would urge you to analyze the information and act accordingly. Although I represent CMC Vellore and CIDS, these are my personal views. Take what is good and correct. Blame me for the wrong ones. And I think it is extremely important to see the big picture, which irrespective of whether you are a physician or a microbiologist or a public health personnel. And therefore, I would try and give you some views on what has been going on and how can we apply this in our day-to-day practice in handling this. Now, you would have heard over and over again that this is unprecedented. You know, what you've been witnessing is really unprecedented. I would like you to think and ask the question back, unprecedented in what way? I think we need to look at the history and the lessons learned from history, and look at the current pandemic, see what are the insights you can gain from that, and how to prepare ourselves for future. How a pandemic struck a British Prime Minister and changed the entire world is known to all of us. Am I talking about Boris Johnson in 2020? No, I'm talking about David Lloyd George in 1918. As you all know, as the World War I was ending by 1918, the entire world was struck by the influenza pandemic. It didn't spare the British Prime Minister as well. Luckily, he survived. I believe he survived for another 30 years. And I hope, although I'm not a admirer of Boris Johnson, I hope he also will do well. Now, there are several lessons from that. Many of you know that this has claimed a huge number of lives, roughly to the tune of 30 to 50 million people across the world. This was also called as Spanish flu. If you really look at why it was called Spanish flu, is very interesting. During the World War I, Spain decided to stay neutral. The countries on both sides were suppressing all their news. And the only country which started reporting openly about the pandemic or the outbreak which was occurring was Spain. And therefore the name Spanish flu. This, even the current pandemic, I'm sure we have gone through the same kind of stories. And if you really look at the current scenario, we are almost reaching 2 million cases, about 1.27 lakh deaths across the world. And this is from the Johns Hopkins dashboard. If you just go, if you Google it, you can get it. You can very up to date. You can get each country's statistics and you can analyze many of these things. And the 2009 pandemic influenza epidemic and the COVID-19 today. There are several things which we would have to try and compare and see, although this is in several respects, it's not really comparable. There are several parallels one can make as well. You can see the number of countries which were involved with the influenza and COVID, almost all the countries in the world, affecting large number of cases. And in 10 years' time, I'm sure the recognition of a pandemic and also laboratory diagnosis, we have gone a long way, and you will see those differences as well. And look at the death rates. And if you just look at the case fatality, the number of deaths over the lab confirmed cases, you see figures which may not truly make much sense. If you start to analyze, there is a lot more to it. I'll come back to that in a minute. The infection fatality rate may give you little more insight into what the reality is. If you particularly look at the influenza, it was definitely less than 0.1% in H1N1 pandemic as well. And COVID is supposed to be around 0.5, 0.6. And look at the transmissibility, the R0. I will talk about it a little more in detail in a minute. And you can see the influenza and the COVID-19, the infectivity is fairly close. Both are very infectious. Now, when you look at the case fatality rate, there's a lot to do with the testing policy which each country adopts. If you look at this picture, UK tests only the severe disease. And therefore, the case fatality, what you get there is 8.7. This is a little while ago. On the other hand, another European country, Germany, was testing both severe and mild and moderate illness. You get a case fatality of 1.3. So definitely your testing policy is going to color the case fatality if you're looking at the case fatality rate in each of these countries. Now the testing per capita in different countries, it is quite evident that smaller countries with a lot of resources, they have gone on a testing spree. And you can see that Iceland and South Korea and Germany, etc., good amount of testing. I'm not saying it is bad. I'm just saying that, per capita testing, if you see countries like India, is extremely low. And you must also realize that a case fatality rate is a dynamic figure, because as the epidemic evolves, people are able to recognize it quickly, treat them better, and it is very well known that the case fatality rate of the same disease in the same epidemic comes down significantly. This is data from China. You can very well see that it is true. What about the asymptomatic and pre-symptomatic infections? What are the implications in terms of the death? Now, there are a few examples you can look at. They've looked at this residents of a long-term care facility in King County in Seattle. 76 residents were tested positive. You can see that at the time of testing, about 43% had symptoms and 57% were asymptomatic. Now, among these asymptomatic people, which is 13 out of them, 10 out of 13 went on to develop symptoms, and 3 remained asymptomatic. So among them, 43% were pre-symptomatic and 13% were symptomatic. If you look at the Singapore cluster, the clusters from the church services and so on and so forth, you can see that the pre-symptomatic transmission is about 13.6%. The Diamond Princess cruise ship data has given us a lot more insight. It tells you roughly what is the infection fatality rate, which is about 0.6%. There were about 3,700 people on board, and 634 were initially tested positive. 51% were asymptomatic on testing. The transmission, we know that transmission occurs about 1 to 3 days prior to the onset of symptoms. So it starts 1 to 3 days prior to the onset of symptoms, and therefore there are a lot of implications for the asymptomatic and pre-symptomatic individuals. And also there is a longer duration of infectiousness for this particular virus. It's roughly about 10 days. 1 week after the onset of symptoms, at least 2 or 3 days prior to the onset of symptoms, and therefore there are a lot of transmission which is occurring from these individuals. In a country like India, where there's overcrowding, there is amplification of many of these factors. the infection fatality rate, when you calculate in a ship, you know that it is very different in a setting in India. Even within India, you know, it will vary from place to place. And even if you take a city, say Mumbai, it is very different in Dharavi, and if you take another affluent area. And children are relatively spared in most places. Do they have a partial protection? Everybody assume that there is partial protection. Is it because of the other human coronaviruses which are circulating? And therefore, the same analogy in people in low and middle income countries, do we have a partial protection to the infection, and therefore are we seeing less severe cases, and we may see much more in the at the base of the pyramid is a question which needs to be answered. Now, when you look at the transmissibility, the best index you can look at is the R0. This is essentially the number of cases which an infected person can go on to, number of individuals an infected person can go on to infect. It's called the basic case reproduction number. For COVID-19, it's calculated roughly around 2.3. Now, R0 depends on three main factors. The duration of infectiousness after a person is infected. I told you about 1 to 3 days before the onset of symptoms, and maybe at least 1 week after the onset of symptoms. The probability of transmission per contact between a susceptible and an infected individual. That again, there is a huge variability of the setting, you know, the living conditions, the interaction with other people, so on and so forth. The average rate of contact between susceptible and the infected individual is the other important factor. As you can see in the graph, it is represented as RE or R effective in an epidemic that R will keep on changing at different points in time. As the epidemic progresses, the R0 will always be above 1. By the time it plateaus, it will become 1, either by herd immunity or the interventions which you do. And then once it starts falling less than 1, it is no more an epidemic. It is on its way to clearance. Now, the R0, you can see that there are, based on the 3 parameters, you can intervene at each of those levels. The transmissibility, the diligent hand washing, coughing, sneezing, etiquette, avoiding touching face, nose, and eyes, so on and so forth. Social distancing, avoiding crowds, and all those interventions will reduce your contact time and duration of infectiousness if you self-isolate yourself. So at each of these parameters, you can intervene. And you can see different countries adopting you know, some of these strategies, and you can see the graph on your top right-hand corner. The highest peak, what you can see is R0 of about 2.5. The middle one is around 1.5, 2.5, around 2, and then the other one is 1. 1.5, I'm sorry. So you can see that with these interventions, including social distancing, you can actually change the epidemic. Now, I'll come back to some of these examples in a minute and compare the R0 of SARS-CoV-2 with that of other viral infections which we commonly see. What about measles? Highly transmissible. And look at the other ones, including influenza and SARS, which we have been seeing. Now, the other important parameters which people occasionally look at is the secondary attack rate. Secondary attack rate is the number of new cases among the contacts who are susceptible over number of contacts at risk. Now, if you take a household of 4, if person A is infected, the red man there, the susceptible people are B, C, and D. And suppose B and C gets the disease from A, you would calculate the secondary attack rate as 66% or 2 out of 3. But this can also occur in a way that A will transmit to B and then B again transmits to C, or the vice versa, A transmits to C and then from C to B. So all these, the secondary attack rate will be exactly the same, 66%. So R0 is considered to be a better way of looking at the transmissibility rather than the secondary attack rate. Now, you will hear this flattening the curve over and over again. You can see the steep black curve with the shaded area under the curve, where there is no intervention resulting in increase in case fatality and overloading of the healthcare system. Pandemic just goes on unchecked, and to some extent, countries like Italy and Spain, what they have faced. On the other hand, if you intervene quickly, if you intervene early, you can actually change the R0. You can flatten the curve. Germany is a typical example among the European countries which has done that. Now, this same concept, moving from a containment to mitigation strategy, we have just written a perspective, it's in print in IJMR, where we talk about the various interventions, social distancing, personal protection measures such as cough etiquette, avoiding touching your mouth, nose, and eyes, washing your hands frequently, so on and so forth, home isolation when sick, care of the vulnerable population. I'll come back to the vulnerable population again. You know that elderly and people with comorbidities are highly susceptible for a severe disease and poor outcome. Widening the testing and treatment capacity. These are all interventions one can do to flatten the curve. Now, you look at the confirmed deaths in several countries, you can see that US had a high toll in terms of number of deaths. They have turned around. UK has turned around. Italy and Spain had turned around. Their curve is downwards. You look at the Southeast Asian countries near, it's very close to the x-axis. I'll come back to that in a minute. But don't merely look at the number of deaths. The population in each of these countries will vary. That will skew your impression. So look at it in terms of per million people. The trajectory, what we are taking is very different from that of what has been seen in Europe, particularly Spain and Italy on one end, and you can see UK is somewhere in between, followed by US, and you can see Germany much closer to the Southeast Asian countries. So the question is, when you compare the other European countries and Germany, what have they done right? So when we talk about the question of many of these tropical countries where BCG is very common, is it because of the protection which the BCG vaccination offers? Is is a controversial question which has been floating around for a little while now. Now, when you look at the basis, if you search in the PubMed, you cannot see even a single article, which means there are no peer-reviewed articles published on this. There are 2 or 3 ecological studies which are not peer-reviewed. These compared the incidence of COVID-19 cases in countries where BCG vaccine is used with countries where it is not used. They observed that the countries that routinely use vaccine in neonates had less reported cases of COVID-19, but you must be careful that this is prone to significant bias from many confounders. If I tell you that, if you put say the nationality or the race, if I may have to quote an example, Caucasians versus the other ones, you will see the same kind of figure. So that doesn't mean that that's the cause. There are several confounders. There are 2 clinical trials underway in trying to look at this. This is from the WHO, most of this information from their website. The other question people often ask is it viral mutation, and are there implications to that? You must remember that this is an RNA virus, and therefore there is no proofreading. The rate of mutation is 1 in 10 to the power of 4, which means that the mutation rate is much higher than, say, a bacterial mutation. If you take TB, the spontaneous mutation which occurs is 1 in 10 to the power of 8 bacilli. So this is much there's a large repository from various countries looking at the bat viruses and things, which has been going on since 2012. And they had this repository had a lot of information of this virus genotype as well. What they found is the type A, this area, it's a confusing figure. I'll try and explain it, simplify it for you. This A type is closest to the bat covey, from which probably is where the virus is originated. There is 96% homology. When you look at the B type, which is here, that big yellow dot, and the types around that, the B type, there is 2 amino acid change. From B, there is another type which is occurred, C type. There is 3 amino acid change. So this is from, about hundreds of isolates, the genotypes from the database they looked at. I would like you to look at it a little more closer. To give you an idea, the genome of the SARS-CoV-2 is about 30,000 base pairs. The base pairs, when we are talking about, is what we are talking about is the nucleotides, the ACTGs, encoding about 9,000 amino acids. The mutational change, what you've seen, is in 3 amino acids. And therefore, when you look at the homology, what is the difference in homology between these 3 types? It's about, the farthest is about 99.7% difference, or the homology is that close. Homology between SARS and SARS-CoV-2 and the earlier SARS-CoV is about 80%. SARS-CoV-2 and human coronavirus is about 78%, and that of MERS-CoV is about 49%. just to give you an idea. So each of these percentages is different from what you see from there. To simplify it further, so if you really ask me, is it really significant in terms of giving the mutation conferring additional virulence or change in the manifestation? I don't think so. Is there mutational change? Yes, there is mutational change. Is it significant enough to cause worry? No. But where is the benefit? You can really trace the pathway from the origin, where, how did it travel, how did people travel, and therefore how did the infection occur from go from one country to another. You can see the type B in UK and Germany, exactly the same type B, but the mortality is very different. The case fatality is very different in each of these countries. You can see that. The proportion of elderly population is likely to have higher case fatality rate, and therefore that is one of the implicated reasons in countries like Italy, where the proportion of elderly is high. I would like you to look at it carefully again. Italy is the one with, this is the small country there, the dark brown, and compare it with the Japan on the eastern side. Both these are almost at the same latitude, just above 40 degree north is what both these countries are. There was a lot of questions. Is it going to be only there? There was a lot of questions there. You can see that both these countries are exactly at the same latitude. The above 70 population in Japan is about 18%. First in the world, and the second country is Italy, which is about 16%. Mortality, case fatality, or is entirely different in these two countries. And they much more to just the elderly or the latitude or things like that. Isn't there much more story? What have we learned from Germany's response? They have demonstrated a low death rate per million population. You can see that Germany has per million, their death rate is about 35. This is as of yesterday. And Spain is about 374. Italy is about 338. UK is about 166. And you can see that there was a robust rapid response, testing through countrywide large network of private and government hospitals and lab, coupled with identifying and isolating infected patients, slowing the spread where the hospitals are ready to care for these sicker patients. Age over 65 is about 21% in Germany, 23% in Italy, and 19% in UK. You can see the entire difference in each of these countries. So they have done something really nice, very different. You can see that they have aggressively isolated and made sure there is physical distancing measures instituted for their elderly. The young ones, they let them loose. They attended carnivals, came back, and many of them were tested positive, but nothing happened. The herd immunity, good proportion in their country, in the younger individuals, but the elderly are protected. India, you can see the trajectory. We are still going up about 1 month into the pandemic. Our numbers will keep on rising, but you have to look at it a little more carefully. A couple of things here. There are 5 states which are the hotspots. Lot of cases we need to institute measures, stricter measures. Kerala is probably a typical example. The yellow line, look at the yellow line, which are new cases per day. It has already shown a decline. The excellent model of control of an epidemic. Now, the things are evolving in front of our eyes, and will replace the local taxis. And as ID physicians and microbiologists, we are very conscious of constant evolution in bacteria and other organisms. These are not unprecedented times. In some ways, there are differences. There are several lessons which we learned from H1N1 pandemic. We were not even testing for influenza before 2009, and look at where we are after that. This is a wake-up call for us. There is a great opportunity. Kerala is a typical example. They have gone through Nipah, done a phenomenal job, and they have done it again. Even a major epidemic or a pandemic, you can control it, is a demonstrated example there. You can actually take it as an opportunity to improve our public health systems, our testing facilities, so on and so forth. So what is the way forward? Intensified testing, isolating and social distancing in hotspot areas, staged lifting of lockdown, the high reporting states, we need to work more, protecting the vulnerable population. Probably what is more relevant is what Germany did, reverse quarantine of the vulnerable population. In hospitals, triaging at the hospital entry, lower the threshold for testing, isolating and cohorting patients, ensuring adequate PPE for healthcare workers, and let's stand together to face the pandemic. The protecting the vulnerable, you know, the elderly and with others with comorbidities have a very high case fatality rate. Just a word about vaccine. There is a good review in NEJM. I won't go into the details. There are two vaccines, one mRNA vaccine, another adenovirus vector vaccine. Both are in phase 1 clinical trial. You can read NEJM review if you would like to get more details. Now, breaking the chain of infection is very familiar to most of us, the ID physicians, and there are 6 interventions you can do: the organism, the reservoir, the exit portal, the transmission, the entry portal, and the new host. And this particular chart has adapted for COVID-19. You can read the details. This will be available. You can read that. The question to you is, where do you stand during the COVID? There is, are you the one which is, spreading the emotions and fear and anxiety? Or are you in the learning zone, becoming aware of the situation, thinking and acting? Or you go one step further, where you proactively handle the situation. To conclude, these are not unprecedented times, and our trajectory is unique. Break the chain of infection, protect the vulnerable, be vigilant and adapt to change, and be the beacon of hope. Thank you very much for your patient listening.
Okay, thank you. Thank you very much, George. That was a wonderful talk, just encompassing the whole world into 30 minutes. Beautiful. I thoroughly enjoyed it. And as usual, we will have the usual volley of questions. In the interest of time, I will just read out the questions relevant to what you discussed, epidemiology, the road ahead, other countries, not the clinical issues. So what would be the best long-term strategy to handle COVID in a resource-limited settings such as rural mission hospitals once lockdown is lifted?
Well, as I said, even in smaller hospitals where, you need to have some way of triaging your patients, cohorting your patients, wherever you have a reasonably high degree of suspicion, you must test. Otherwise, you're going to spread, the infection is going to spread to other vulnerable individuals in the hospital. They are already sick and that's why they are in the hospital. So those strategies which I talked about in the hospital are the most relevant ones.
A couple of questions on testing. How much more should we have tested in the last month or so? That's the first part. Secondly, what is the role of testing in a pandemic, epidemiological versus clinical? And any comments on that?
Yeah, so testing has different strategies at different stages. Now, initially, you would want to test as many people who are coming in so that the tested positive ones, you isolate them, you contain the disease. Kerala actually did to a large extent. They managed to show that that has come down. The rate of infection has come down. Now, won't there be infection spreading in the community eventually? Given the transmissibility, I'm sure there is infection keep on spreading in the community. But what we are trying to do by all the social distancing measures is to flatten the curve. So testing is also part of that strategy. Once it's in the community, there is community transmission. Your resources, whatever you have, you would try and allocate it to the ones which with significant symptoms. So moderate and severe disease, you isolate them, you cohort them in the hospitals, you don't allow them to mingle, use PPE, so on and so forth. Once the epidemic is further down, then the antibody testing for epidemiological understanding, and also the from one area to another it may vary, and you can make interventions based on those findings.
Okay, next question. COVID is going to stay on after the acute epidemic is over. How are we going to change healthcare on a long-term basis in the future?
That's an interesting question, which I'm also trying to figure out how we will handle this. My personal guess is it is likely to be very similar to H1N1 because there is a receptor in the host, and it has been in the host, a reasonable number of hosts. There are asymptomatic carriers. So it will continue for some time. My guess is by the end of the initial epidemic, which will be at least by June, July, we will have about 30–40% of our population who are infected. And then, like in H1N1, I'm sure you will start seeing lower numbers. Maybe another, proportion, another 1/3 or a little more of the susceptible population. So the denominator becomes substantially less. You will see it next year. As the susceptible population comes down to less than more than comes down, and the infection has occurred in 60–70%, then it will come down and resurface again. It may become part of the usual coronavirus. I wouldn't be surprised, but I don't think there is any data to interpret that.
Okay, your comments on routine pre-op testing for all patients as planned by some hospitals.
Well, I think it's a bit too much because that may not be very practical. I understand the question because there's a lot of implications if there are somebody who's positive. So my suggestion is every individual, you should treat them as potential transmitters. And therefore, if you take precautions, what did we do with HIV infection to a large extent? You know, the same way, you have to take precautions, particularly in the next several months to come. But I don't think universal testing is the answer.
Who should be tested under the pooled PCR testing protocol? As you know, ICMR put out some guidelines a couple of days back. And should you do PCR or PCR plus antibody?
Well, the pool testing is in the setting where the incidence is extremely low. ICMR has roughly given the figure of 2% or less. So there, it makes sense to do pooling. So that will vary from state to state and region to region. And therefore, I don't think we can apply this all across. But pool testing, yes, in very low transmission settings.
Why do you think the number of infected cases are very low in India compared to the total population?
I'm also trying to figure that out. We are trying to look at data. One is, if you look at the infected individual, I don't think it will be very different. The infection is inevitable. The transmission will occur. The number of severe cases and the mortality, I think, will be very different. I don't think it will be huge. There are some reasons. Number one is our elderly population, above 70, is only 3.4%. That itself will bring down our mortality, number one. Number two, like in children who has some cross protection, I believe there will be some cross protection with the other coronaviruses. This is just presumption, no data. It is not based on any evidence. So we are trying to look at that particular question.
Any critical contact time for COVID to reduce the R0?
Contact time, roughly they say 15 minutes, but that again is, you know, there is a lot of variabilities. What if it is, you wash your hands periodically and you have full PPE or you have partial PPE, so there is a lot of variability.
Approach to senior citizens in the family.
Of course, they are the ones should be protected. So I think reverse quarantine is what is needed for us.
Any chance of smallpox vaccination protecting against COVID?
I guess it will be something like the BCG story.
So do you think Germany kept its number of cases low because of pooled testing or other reasons?
Can you just repeat that again?
The reason, why did Germany have fewer cases compared to other parts of Europe? Did they pool their PCR, RNA PCRs? Is that how they rolled out testing?
Yeah. No, I don't know whether they pooled their cases, but I know their testing strategy was quite high. Among the European countries, that Germany was one of the good ones. Per million population, their per capita testing was high. But I'm not very sure whether they pooled it or not. They did a lot of testing.
Okay, so as an ID specialist, what kind of relaxation would you recommend during after lockdown is over?
What kind of relaxation? So I mentioned a couple of things. One is staged lockdown, because I think states like Kerala can relax, But states like Tamil Nadu, we have to be more vigilant. We have to be more active in doing our interventions.
Apparently, Sweden has acquired a lot of herd immunity and therefore has fewer infections. Your opinion on this?
UK started off with that. But what they found is, see, these long-term care facilities, if you don't protect them, if you see, I mean, if you've worked in UK, you will realize, or US, many of these caregivers, they go from one place to another. So they transmit the disease from one place to another. The countries like Germany and Sweden and all that, there are several of them. They managed to make a lot of interventions in those areas.
What can you explain the herd immunity in the younger German population? How did that help, etc.? Clarification.
Well, the herd immunity, if you see, there was a report, I mean, I haven't looked it up recently. There was a report of a carnival where a lot of these youngsters going for a carnival and many of them coming back and tested positive, but most of them did not have any significant symptoms. So the herd immunity is good for the these kind of epidemics. It's ultimately the susceptible population who get the disease. So as the susceptible population come down, the R0 comes down and the epidemic will become no more an epidemic.
Okay, George, I know you're a proud Keralite. Could you throw some better light on their model?
But I have lived more than half of my life in Tamil Nadu. So in that sense, I'm more of a Tamilian. The Kerala model, I think what the lessons, what they have learned is from the Nipah, handling the Nipah has really helped them. Their testing strategy, going around testing even the contacts, thousands of contacts and testing them, quarantining them, police very strictly instructing not to, gather together, so on and so forth. It was, I know it was very strict. So primarily social distancing, testing, quarantining, isolating, some of these strategies are the ones which they did.
One question, once social distancing measures like lockdown are relaxed, will we get a second wave and how will we manage that?
Well, possibly yes, and that's why we have to do staged this thing, and there will be some amount of transmission in the moment you bring down the R0 to somewhere closer to 1, even if it is not 1 or less than 1, you're much better equipped to handle the cases in the hospital and also the vulnerable population, so on and so forth. So that's the advantage.
Comments about reverse quarantine.
Reverse quarantine is what I mentioned about the susceptible population, you quarantining them. They don't have any contact. Even before they developing a contact or disease, you quarantine them.
Okay, and how to apply triaging in a common hospital, basic screening unit before specialist sees them?
The last bit, Ram.
You need a basic screening unit before they move into the rest of the hospital, before a small general hospital?
Yeah, so I think the idea is to pick highly susceptible population who have got other comorbidities and things like that. So many hospitals, you may have seen the fever clinic and you know, the triage clinic, whatever you want to call it, where you triage patients who are likely to have COVID-related symptoms, any upper respiratory symptoms with fever, with or without fever. So the three cardinal symptoms of fever, cough, and breathlessness are good screening tools.
I think you briefly dealt with this evolution of the virus from China to India. You dealt with this. Any comments?
There are two viral strains which they have sequenced in NIV Pune. I think it was just two. There's a publication in IJMR where they said the homology is very high. So as I said, the homology between all these strains are to the tune of 99.7%. So that is what you will find now.
Okay, last 2 or 3 questions. Your comments on chemoprophylaxis for healthcare workers.
Well, that's it is not something which I would recommend. I have not taken any chemoprophylaxis, and I don't plan to do it also. There are where will you apply to very specific you know, population who are at risk, maybe somebody who's elderly, continuing to see patients, or the other comorbidities and so on and so forth. Hydroxychloroquine is where there is some evidence, but there are clinical trials showing that there is toxicity and issues related to that. So it has to be very carefully done till we have the results of the RCTs available.
Your comments on weather in the subcontinent, will that affect transmissibility?
Whether the?
Weather, we're getting into summer now, and do you think that will affect the virus?
Sure, sure. Yeah, I think that was the quick answer I have is it may bring down the temperature. I mean, the higher temperature may bring down the rate of infection a bit, but our overcrowding will compensate for that. So there are several factors this way and that way, but it won't completely destroy the virus. You need to destroy the virus, you need to have 50+ degrees. So which is, anyway, we are not going to achieve that.
I think in Vellore sometimes it gets almost that hot. So, so is it, the final question, once vaccination is available, how long shall we be protected?
That's a very difficult question to answer because we don't even have a vaccine. I think we are at least 1 year away from the vaccine, maybe even more. The only 2 vaccines which are in phase 1, we have to see how long the protection will be, and you know, that depends on how quickly this will mutate to become a significantly different virus.
Okay, so we're basically running out of time. Thank you so much, George, for a wonderful lecture. I learned a lot, and I'm sure our audience would have learned ever so much. Over to Dr. Senthur Nambi.
Thank you, Dr. George M. Varghese, for giving an excellent overview and with probably key points learned from each of those individual countries, starting from Japan, South Korea, Germany, or even in India, the state of Kerala. Probably there could be a Kerala model to be followed with every other state, which has increased numbers. Thank Dr. Ram Gopalakrishnan for moderating this session. And already I've had a lot of requests and chat saying that we got used to this lecture series an everyday afternoon for the past 6 days, and we'll be missing it. And there are already requests from, that we have had attendees from US, Canada, Australia, New Zealand for our lecture series. Even if it happens in an odd time there, they've managed to kind of key in those for those lecture series. And what I want to say is, we may not go away. Probably we'll come back soon with a different format. Instead of being a lecture like this, probably have much more interactive with real life case scenarios, and probably a session on critical care management in the patients with COVID. That is something that we are planning. And we have the details of accessing all your email IDs. So probably we'll get back to you with a new version of the program so that we are much more up to date with the newer advances in the management. And there has been request for sharing the PowerPoints. All I would say that is sharing the PowerPoints may be a little difficult. Anyway, those lectures with the contents there in the PowerPoint are easily accessible. All you have to do is go into the CIDS website, sidsindia.org, where all the lectures are loaded in. Plus, you could also access the lectures through the YouTube channel, where you have to type in CIDS webinars. That is what is required. And as of now, I thank all the speakers for putting in efforts to come over and then give these lectures. And I thank all the viewers who had spared time over 6 days at a regular time, 3 to 4 p.m. And probably CIDS would come up with much more interactive sessions, and hope we continue to serve well the country of India. Plus, we have a hold on the COVID pandemic. Thank you for the organizers, especially the Hallmark events, who put in effort to contact the attendees. And thank you, viewers, for joining in. And as of now, bye-bye. We will meet you soon, sometime next week, with a newer version of the program. Thanks, Dr. RJK, and thanks, Dr. GMV, for putting in the efforts today. Thank you.
Thank you. Thank you very much, Ram. And
Thank you, Nandi.
thank you, Nandi.